some seem to view the lives of those with Down syndrome as less worthy than others. And you give an example of a man in his 20s who attended the cardiologist with his mother, and the cardiologist during the pandemic said, "I do not know whether it's worth operating on someone like him." What happened in that case? Did the young man get the treatment that he required? You mentioned in your statement that a seriously ill woman in her 80s received a call from the GP in respect of her fit and healthy son who was in his 40s, with the GP stating that she wanted to place a DNA CPR decision on the woman's son's file. Good morning, Mr. McConnell. Your full name's Eddie McConnell, is that correct?
That's correct.
And you're the Chief Executive of Down Syndrome Scotland.
That's correct.
Could you tell us a bit about the work that Down Syndrome Scotland does, please?
Yes, I'm happy to do that. So Down Syndrome Scotland is the only charity in Scotland that supports people with Down syndrome and their families from birth right through to their older age at every stage.
And I want to move on to speak about the clinical frailty scale. Now, my understanding is that that scale is designed to apply to people who are perhaps elderly or through or who have a condition that is terminal and they are close to the end of their life. But during the pandemic, you found that it was being applied to those with Down syndrome. And your organisation took action for that. When you contacted the government, how did you find the response and how quickly did they react?
So I would have to say that they responded in shock initially when we contacted them to make them aware that a number of families had reported to us that their loved one was possibly not going to be prioritised for treatment. They were in hospital, but they were not going to be prioritised because somebody had completely inappropriately used the clinical frailty scale, just because the person had Down syndrome. And that's a wholly inappropriate use. And indeed, I have to say they moved very quickly, and guidance came out to say that the clinical frailty scale should not be used in determining support and treatment for people with learning disabilities, and in particular people with Down syndrome. So that, I have to say, that happened very quickly. That guidance came out. Of course, it was just guidance, and we're always aware that when it's guidance, it doesn't carry a statutory. It wasn't a statutory instrument, and the consequence of that is we then redouble our efforts to make sure people know locally that this guidance has come out. But similar to my earlier comments, the gap between that national guidance coming out and local implementation was very varied. And of course, there's that substantive point that it remains guidance as opposed to an instruction or a statutory instrument, if you like.
Yes, and you make the point in your statement that generally across primary care, and I think implied in that also is in hospital care, that some seem to view the lives of those with Down syndrome as less worthy than others. And you give an example of a man in his 20s who attended the cardiologist with his mother, and the cardiologist during the pandemic said, "I do not know whether it's worth operating on someone like him." It's quite a profound statement, even if they're not mistakenly using the clinical frailty scale. What happened in that case? Did the young man get the treatment that he required?
So my understanding is he did get the treatment he required, but it required an intervention from us as a charity to explain why that was a wholly inappropriate response. This is an issue that our community sadly live with day in, day out. There are many great health practitioners, many great medical professionals who understand the value of people with Down syndrome and who understand that Down syndrome is a genetic condition. It is not a disease, it is not an illness, it is a genetic condition. and that what you need to focus on is the health conditions that might be associated with that. But never, ever use Down syndrome as a reason not to treat people or not to prioritise them for treatment. We know that despite the efforts of the last 40 years, where we have extended life expectancy of people with Down syndrome, when the charity started, life expectancy was just 20 years. Today, life expectancy is 60 plus, 70 plus. But it remains the case that for people with Down syndrome, they continue to die on average 28 years younger than the general population. And in the majority of those cases, those deaths are preventable and certainly premature. And we know from research conducted by the University of Glasgow that it is often ignorance and prejudice about the condition that results in people having wholly inappropriate views about the individual who just happens to have Down syndrome. So the person was supported, but it required a very heavy intervention by our charity to bring about a different change in circumstances.
These views exist generally, but during times of stress on the NHS or during pandemics, it just becomes much more prevalent. And presumably if somebody isn't used to working with your organisation, then they have to either deal with this themselves or just accept the view of the clinician that their child isn't someone worth carrying out this treatment on.
So we're very clear that at best it's ignorance that creates that view of a clinician, but actually in some cases it's definitely prejudice and discrimination. So we work very hard as a charity to tackle that through training. This is an issue that has existed for our community long before pandemic came along, but it amplified. It was amplified. We were shocked to discover how quickly it came to the surface and how prevalent it was in the pandemic. So we've always known it's there, but we were quite shocked. And the most obvious example of that was in the conversations around do not resuscitate orders.
Yes, and I actually wanted to come on to that now. So do not attempt...
about 10 minutes.
Thank you, my lord. The do not attempt cardiopulmonary resuscitation or DNA CPR. You mentioned in your statement that a seriously ill woman in her 80s received a call from the GP in respect of her fit and healthy son who was in his 40s, with the GP stating that she wanted to place a DNA CPR decision on the woman's son's file. And the woman, you say, was quite surprised by this. She perhaps, you imply that she perhaps expected a call in respect of herself, not her son. Do you think that that was an isolated incident? Or do you think that these conversations in respect of people with Down syndrome were taking place very frequently?
So we definitely know it wasn't an isolated incident. We know that a number of families had unsolicited calls from, in this instance, that particular example, from the GP's practice. Mum in that instance was actually very confused as to why the conversation was happening, because her own health was extremely compromised. Sadly, she's no longer with us. She has passed away. So she was confused why the call was about her son, who was in his 40s, a very fit, very active, healthy man, who in fact had no significant health conditions. So she moved from a position of confusion, reached out to us, to a position of real anger, because she could only her only rationale for that conversation taking place is because the GP that made contact had decided that because her son had Down syndrome, that maybe we should just put, if you forgive me for using the short term, do not resuscitate order in place, just in case. And it's completely wrong. It's completely unacceptable, and it reveals terrible bias, and frankly, we would say prejudice against somebody who happens to have Down syndrome. We moved very quickly to escalate that within Scottish Government and within Public Health Scotland. I have to be honest and say that the response we had to the clinical frailty scale issue was quite rapid. I'm probably less clear what the response was on the do not resuscitate orders, but I know that guidance was eventually issued after a number of months to be clear that while people with Down syndrome are part of society in general, and we know that society in general, there will be times for conversations about the appropriateness of a do not resuscitate order. It can never be justified to have that conversation just because the person has Down syndrome. Down syndrome is not an illness, it's not a disease, it's a genetic condition.
Yes. And to your knowledge, did the GPs listen when people said they didn't want this? Because we know that clinicians are able to place such notices on people's files, regardless of agreement. Best practices that they discuss it. But in these cases, did GPs proceed to just place these notices on people's files, or following a conversation with the families, did they agree that it wasn't appropriate?
I think our recollection is that following another heavy intervention, most stepped back. We couldn't be certain, though, that these orders weren't, and we certainly know of one family where an order was put in place wholly inappropriately without the knowledge of the family. So that was completely unacceptable.
Yes. And you say that eventually perhaps some communications were put out that this was inappropriate. Where a notice was placed on a file, do you know whether that led to GPs revisiting previous decisions that were based solely on an individual having Down syndrome, or do those individuals still have DNA CPR decisions on their file?
We don't know for certain, and one of our challenges is that the families who reach us, we often believe there are other families who don't reach out to us, who maybe, because of other pressures they have in their lives, be very deferential to that clinician's viewpoint. So we do know that even if it's one family that reaches us, we have to respond, because we suspect there are many families who haven't reached out to us and find themselves in a similar position. So I can't say with certainty whether those orders still sit on their files or not. I think it's probably for others to answer that question.
So thank you very much for your time.